Well, good afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town. It's blue skies and it's hot and balmy outside. And for those of you that aren't here, we wish that you could come and visit us sometime. It gives me great pleasure to introduce the Pelvic Floor Foundation's talk this afternoon, Professor Ermos Nicolaou, who's at the WITS Health Consortium and the Morningside Medical Clinic, and he's head of the WITS Maternal and Fetal Medicine Center Foundation. So, Ermos, it's wonderful to have you over here as always. I'd like to thank Chris for being with us, and of course, my co-host, Professor Stephen Jeffrey. Steve, it's always nice having you here.
Yeah, absolutely. Welcome back from your little operation.
A little operation.
Yeah.
Steve, it's easy for you to say little operation. So it's a little operation from your point of view. From my point of view, it's a big operation. In fact, it was two operations. Now, I had an operation. I'll just say, Ermos, I had an operation, and in the course of this operation, the light handle from the light above the operating theater came loose and fell on my head. It's one of those metal light handles, and as it fell, it just unfortunately fell on the angle and cut my face open right between my eyes. So I had two operations. The orthopedic surgeon had to stop the operation and go and put some chromic in my head to stop the bleeding.
Did a good job.
Did he?
Yeah.
Well, I don't know.
Yeah.
Chromic in the head from a.
You look good.
Did they struggle to wake you from the op?
No, they didn't say I was. They struggled to put me to sleep. I was awake the whole time. So that's just as an aside, Ermos. Don't go for orthopedic operations. It wasn't at this hospital. It was another operation, another hospital, Steve. So don't have to worry. No, wouldn't be. Anyway, so it gives us great pleasure to have Ermos with us. Ermos, it's great as always to have your talk, Ethics in Obstetrics and Gynecology, and some take-home some take-home messages here. So, Steve, without further waste of time, thanks to Chris for setting everything up. And then if you could share your slides, Ermos, Ethics in Obstetrics and Gynecology. Thanks very much.
Okay, good.
Thank you to both of you, and thanks to Chris for organizing this talk. And gives me great pleasure to be again on your prestigious platform, and hopefully we'll have another talk later in the year. I'm sure we will, and I'll do it with pleasure. I want to just get rid of the video screen so that we can optimize the quality of the stream.
Sorry, Ermos, just to remind people, we have a very large audience here. Just to remind people that Professor Nicolaou gives his own webinar on Tuesday evenings from 5 to 6. They're in obstetrical nature, well worth attending. It's wonderful to have this other resource with us. And so, Ermos, thank you very much indeed for taking that time and trouble also to do that for us. But thank you very much indeed, Ermos.
Thank you, guys. And it's a bit of a longish talk because lots to talk about. So let's get started.
Yeah.
If at any point you can't hear me or see my slides, please interrupt me. Otherwise, we'll have a discussion probably towards the end. If there are any burning questions, I'm sure you can shout. Obviously, I can't see you once I have my slides on, but I will probably be able to hear you. I put this cartoon on because it's exactly to the point of the topic today, where the doctor tells Hagar and his wife, Helga, you should trust doctors more. Our first rule is do no harm. And Helga says to her husband quietly, it worries me that they need a rule to figure that out. There is a lot of confusion and a lot of diversity around the world. And at the end of the day, the law of the land dictates what is allowed to be done. I put two extreme examples here, and I didn't cover the faces of these two kids because they were readily available on the internet. So it's not something that I needed to cover. On the left, I have a cutting from a newspaper in Denmark that says very proudly that Denmark soon will be a country of not a single citizen with Down syndrome, which is such a terrible, obviously, disease, according to the Danish newspaper. So not a single citizen will be born with Down syndrome. They're so proud of that. And on the right, I have a little kid with Down syndrome. That's in the States. And she says, I am one of the 10% children lucky to be alive because I wasn't terminated. So have we gone too far is the question. So to make things even more complicated, we are bombarded with accusations, medical negligence, legal firms. You hear in the news in the morning or just before the news on 7 or 2 or whatever, have you had any bad experience with your doctor? Call us, we will defend you, we will look after your interests. So it became a bit of a lot of doctors actually feel that they can't carry on anymore. And some of us even give up obstetrics or give up medicine altogether. We rush to the courts to get answers, but the answers sometimes do not come or do not come the way we expect them to come, because as everybody knows, truth does not always equal justice, nor justice truth. There was one case, and I use this as a case study here, that says there was a claim for damages for wrongful suffering of a child born with Down syndrome. And that case went from the lower courts to the Supreme Court of Appeal to the Constitutional Court and back to the lower courts. The question the judges were asked was, what is wrongful birth, and should that child with Down syndrome be born? And the judges said, well, we can't really give an answer because this goes to the heart of what it is to be human, something that should not be asked of the law.
So Ermos,
Yes.
on this case, what
Yes.
was the outcome then? Was it hung, or was there no outcome, or what did the Constitutional Court judges finally decide, and where did this go?
So it didn't go anywhere. It's still, as far as I know, and I may not be up to date, but I spoke to the mother of this child. It's a case in another province, not my province. And look, she loved the child and the child was happy, but obviously she was very upset about the fact that she ended up having a child with Down syndrome that she didn't know that she was getting, and she was trying to get some justice. Now, whether justice is served by finding a doctor negligent or not, it's something that we need to debate. And that's the very crux of probably what we will be discussing today.
Yeah.
Recently, on ENCA News, there was this interview with the Minister of Health saying openly, and actually they put the name of the law firm here, which I covered because I didn't want to mention names, that a law firm in Gauteng was paid over 370 million rand for claims in a period of 3 years. And none of these claimants who got this money awarded to them were actually real people or even had accounts registered to their names. That's a lot of money to be made. And when there's money to be made, there is usually trouble. So I want to go back to the basics, what we learn as medical students when we study medicine, the principles of ethics in medicine: beneficence, the intention to try and do what is good for the patient, and this sometimes may conflict with the patient's autonomy. Non-maleficence, first do no harm. We always think, no doctor, I don't think any doctor gets up in the morning and thinks I'm going to cause some harm today, but things sometimes do go wrong, and sometimes we are accused of negligence and so on, which is even more traumatic for us because actually that was the last thing we intended to do. Respect for autonomy, the individual's right to self-determination, as well as creating the conditions necessary for autonomous choice. And distributive justice, the fair allocation of resources among diverse members of a community. Our Constitution says everyone has the right to have access to healthcare services. And I put in brackets, that's my little sub-paragraph there. Does this mean resuscitation at all costs of a child, of an infant of 500 grams that has a 50% chance of not surviving. And if it does survive, another 50% chance not to be 100% neurodevelopmentally well developed. No one may be refused emergency medical treatment, and the state must take reasonable legislative and other measures within its available resources to achieve progressive realization of these rights. So that's the very foundation of, human rights and medical care in this country, our constitutional rights. If we go to the patient's autonomy in obstetrics, defined as an adult with capacity to make decisions, may decide what may be done to her body. That includes refusal of any treatment, even if we disagree with the patient. The rights of the mother, the surrogate mother, the teenage mother, and the obstetrician's role. The patient decides to bring the baby to us, and therefore the baby, the fetus, becomes our patient only because the mother chooses to present her baby to us. So caring for the fetus only becomes possible because the mother allows that, and she can withdraw from that care at any time. What about teenage mothers and their autonomy? The law in this country is pretty clear that any person over the age of 14 years shall be competent to consent without the assistance of her parent or guardian to the performance of any medical treatment of herself or her child. And further down, the Act of 1996 says that defining what is the legal age to terminate pregnancy, age at which a child may terminate her pregnancy, any age. The assumption, of course, is that it's old enough to fall pregnant. So it would be 10, 11, 12. Obviously, there is a bit of a variation there. The TOP Act defines a woman as any female of any age. It further states that only the woman's consent is needed for the TOP, and in the case of a minor, only the minor's consent is needed, subject to advising such a minor to consult with her parents. So she doesn't have to, but we recommend that. We see a lot of surrogate mothers nowadays. What is the law about surrogacy in South Africa? Well, there are some terms and conditions, of course. The surrogate mother must already have at least one living child and must have given birth to a child to be an eligible candidate. One may not commercially gain from the agreement as surrogate mother, other than being compensated for relevant expenses. And that's a loophole, as you can understand. So relevant expenses can be interpreted in many ways. The surrogate relinquishes all parental and contact rights with the child and can only have contact or relationship status according to the agreement that was signed before she became the surrogate mother. Should the fertility treatments, however, commence without prior confirmation of the agreement by the court, the surrogate mother may end up being the rightful parent. The agreement,
Ermos?
yes.
Ermos,
Yes.
on that point of, there is it, the compensation, just and fair compensation.
Yeah.
Your opinion that sometimes the surrogate mother does get paid more than just compensation
Absolutely.
medical, and she gets shall we call a sweetener? Does it happen?
Absolutely. Absolutely. I mean, officially not, but as you know, nobody would, unless it's a sister or a mother who wants to help her child, nobody would go and donate her body to carry someone else's, especially someone she doesn't know, just because she, wants to help. It may happen, I'm sure, but most of the times, this is a loophole allowed, basically, to be there to compensate indirectly, if you wish, for relevant expenses.
Okay, so is it legal or not?
Well, the law needs to be interpreted by legal minds, but if you look at it this way, it's not legal to give money into her account, but legal in terms of I will give you money to go and buy groceries and be healthy and get supplements and buy nice clothes because I want you to look good during the pregnancy. Well, that is
Okay.
touch.
I get the idea. Yeah.
Yeah.
It depends how elastic your principles are, shall we say.
But you will find as we go on that there's a lot of loopholes and interpretation that can be interpreted in many ways.
Yeah.
And maybe on purpose. Maybe those who wrote these laws allowed this to happen because otherwise there wouldn't be anybody offering her body as a surrogate.
I get it. So if you know, the corollary is that if they were 100% strict and you weren't allowed to be elastic in your interpretation, you wouldn't have any surrogacy at all.
Yeah, I think so.
Okay.
So the surrogacy agreement must be ethically acceptable by all parties. Clinics must not facilitate treatment under a surrogacy arrangement if there are concerns about whether the arrangement is ethical and or legal. So this may answer your question, Peter, as well. Yeah. This is an important point. The surrogate has the right to terminate the pregnancy upon discussing her decision with the parents. Now, let's, for example, say there is an abnormality. You see the surrogate mom and the biological parents coming with the surrogate mom. There's an abnormality. You want to do an invasive test, a CVS or an amniocentesis, and the surrogate mom says, no, I do not agree. I do not give consent to have a procedure. I'm too scared, or whatever. So that's a problem. Will that then pregnancy continue with the baby being abnormal? Will then the three parties, the surrogate and the parents, agree that this cannot carry on like this? Rather, let's terminate. And again, the surrogate mother will have to agree to present herself for termination. And of course, there are different parts of society that feel that on the one hand, assisted reproduction is, what technology has to offer in medicine and should be embraced, because otherwise some couples would never have the beauty, the luxury of having a child unless there was someone to help them in an IVF lab. On the other side of the coin, of course, there is the section of the society that is very religious, and they feel this is a contradiction to the religious faith and should not be offered because that's interference with nature. And of course, everybody must debate this in a forum that is appropriate for this discussion, whether should be offered and how. Of course, it is being offered in most countries. I think in more religious countries, maybe there's a bit of a caveat there, but we'll come to the American situation in a moment where abortion, for example, is now being frowned upon in most states in America. So,
yeah, I'm glad you're going to talk about that because,
yes,
my sister lives in America, and is it not only not frowned upon, it's actually prohibited. It's illegal to have a termination, and women have to cross borders to have that privilege if they wish to.
Absolutely. We'll come to that in a second. Yeah. Before we go to the American situation, this is just to refresh your memories. The South African Termination of Pregnancy Act, upon request up to 12 weeks, the pregnant woman decides she doesn't want to have the baby anymore. It is her right, constitutional right, to request termination. From 13th to 20 weeks of the pregnancy, if a medical practitioner, in consultation with the woman, is of the opinion that continued pregnancy poses a risk to the woman's physical or mental health, a substantial risk exists that the fetus will be severely abnormal, the pregnancy resulted from rape or incest, and the continued pregnancy would significantly affect the social or economic circumstance of the woman. As you see, there's such a big spectrum of interpretation. What is, for example, significant risk of mental or physical abnormality? What is that? 5%, 15%, 50%? And who decides that is 50% and therefore you qualify for termination, or they significantly affect the social or economic circumstance of the woman? Again, a big loophole where the interpretation can be, anything up to the patient and the doctor, really. After the 20th week of pregnancy, if a medical practitioner, after consultation with another practitioner or a midwife, is of the opinion that continuation of the pregnancy would again result to the same things, pretty much like under paragraph 2. So as you can see from this law, the interpretation is, it's can be very subjective. And if all else fails, you involve a psychiatrist who will say, okay, the baby is viable, it's after 24, 26 weeks, but continuation of the pregnancy may result in the mother committing suicide. And therefore you say, okay, that is now covered, a good reason for the pregnancy to be discontinued.
Ermos,
Yes.
can I, just before we get to Roe versus Wade, in your last slide, we sometimes have very, very difficult, that's it. We sometimes have very, very difficult questions over here. When is a woman allowed to terminate or not? And a recent case over here is a woman that had a baby that was achondroplastic. And she said achondroplastic babies are ugly, and she doesn't want an ugly baby. And this caused huge confusion and a lot of trouble and heat. Is when is a termination allowed, and when should a woman be allowed to terminate? And is that a valid indication she just doesn't want an ugly baby? What is your feeling on that particular point?
So towards the second half of the talk, actually, we will go over some abnormalities.
Okay, sorry.
Achondroplasia. No, but just to answer here, it's exactly what I just said. Okay, so now you say, as a doctor, you don't feel achondroplastic dwarfism is a significant or severe enough abnormality to justify termination. The patient, on the other hand, says, no, I'm now very depressed. I can't really cope. I can't live with the thought that a child of mine will be a dwarf. So you send the patient to a psychiatrist who will then assess the non-obstetric side of the situation and say, well, this patient is suicidal. And therefore, I concur with her that termination should be offered. So she comes back to you and say, yes, but I disagree with that. And I do not want to do it, but I will refer you to another center or a hospital where this can be offered. And that's where we will be discussing a bit later. So we're still obliged to refer the patient to someone who will be willing to do that, even if we do not want to perform a termination. And nobody can force any practitioner to perform a termination if he doesn't want to, for various reasons. Religion is one of them. But you must then refer the patient to someone. Direct referral, in other words.
Yeah.
So going to the American situation, it's an interesting topic to discuss because everything started with the Roe versus Wade in 1973, where a woman wanted to have the right to terminate the pregnancy. She said she was raped. It took, as you can imagine with these matters, took ages for the Supreme Court to reach a conclusion. By the time they reached a conclusion, she did have the baby. And years later, she said actually she was kind of forced to say that she was raped, and it was all untrue apparently, and she now changed her mind and she's against termination. Nevertheless, in 1973, the Supreme Court in America discussed the case, and the court found that it was a right to privacy under the Due Process Clause of the 14th Amendment extended to a woman's decision to have an abortion. And in other words, they allowed her to have an abortion, but obviously it was too late. Interestingly, the justice who wrote the decision, a few years later, I think a year later, in 1974, in a television interview, said, well, she had mixed feelings about the whole thing. He is not sure whether what they did was a good thing or a bad thing. He said, this case will be regarded as one of the worst mistakes in the court's history or one of its great decisions. that was, in any case, a turning point. Fast forward many years later, in 2022, Dodds versus Jackson's Women's Health Organization, where eventually the Supreme Court overturned that right of a woman to have a termination, even in the first half of the pregnancy. And the explanation, as it was written by Justice Alito, was that the only legitimate unenumerated rights, that is, rights not explicitly stated in the Constitution, are those deeply rooted in the nation's history and tradition and implicit in the concept of afforded liberty. And abortion does not belong into that group and therefore is not a right. So that opened a can of worms. So 2021, 2022, Texas, I think, was the first state, and many followed after that, where they passed a law that says, and they called it the Texas Heartbeat Act, where from 6 weeks, when there is a little fetal heart present on the ultrasound, termination is no longer allowed. So much so that individuals in the community, if they know of a case that went to have a termination after 6 weeks, they can go to the police, lay charges, and they get $10,000 for their efforts. Now, of course, as you can imagine, and as Peter said a moment ago, this creates a problem. I work in Texas, in Houston. I've got an associate professorship. I go there regularly. When we see abnormalities, severe abnormalities, sometimes anencephalic babies, we're not allowed to offer termination in Texas. These patients are told to go to another state. Usually we send them to California to have a termination there because that is still allowed. If you look at the bottom little paragraph here, in the UK, a woman with Down syndrome said she planned to take the UK to the European Court of Human Rights in the long-running challenge to the law allowing late abortion of a fetus with Down syndrome. So a lot of things are happening around the world, and that creates more confusion, anxiety, and doctors ourselves, we need to be counseled, and you need to be informed about what are our rights and what is that is expected from us. If we look at the baby itself, because we mustn't forget we're dealing with the mother and the law, but we have also a little patient that is inside the mother's tummy. Does the baby have legal rights? Does the fetus have a moral status? And the answer is not. In the South African law, the fetus does not have independent moral status, does not generate its own rights, and there can be no autonomy-based obligation to any fetus. However, we all feel very concerned about treating a fetus as just a law, as an object. So there is another act, the Human Embryo Act, and the Prohibition of Human Cloning for Reproduction Act in 2002, that basically says you cannot really use human embryos outside of human body for any reason, including research. What about viability? We discuss this a lot, and we say, can't be offered before the baby becomes viable. After viability, a lot of us have a problem because we then need to perform feticide. Is viability really such a significant turning point? Well, the definition of viability is that the baby will be able to survive outside the uterus, outside the natural incubator, without or with technical support. And to a lot of people, viability is a morally significant point in pregnancy. The law, as you have read a moment ago in South Africa, talks about 20 weeks. Realistically, we should be actually talking up to 24 weeks, because really up to 24 weeks, pre-viable babies, we find it, if not just technically easier, also morally a bit easier to perform a termination of pregnancy. because of severe abnormalities, whereas after 24 weeks, after the baby becomes viable, in other words, may survive even if you terminate, those become more difficult decisions and discussions to have.
So Ermos,
Yes.
where do we draw the line? Is it it's a different line, it seems. The law, you said, it was 20 weeks,
Yes.
and practicality is 24 weeks. Is that correct?
Yes, yes. But remember, if we go back to the law, after 20 weeks, if there is a risk of significant risk to the mother's health, significant abnormality in the fetus, again, you're allowed to, with another colleague, to say, okay, let's offer termination. So although the law is vague from 20 weeks onwards, we feel up to from 20 to 24 weeks, we can still feel more comfortable with the idea of termination. But after 24 weeks becomes a bit more critical because of the fact that you now have to perform a feticide and then terminate. And that feticide procedure, where you basically kill the baby before he's born, some people found morally more difficult.
Okay, so there's a gray area.
It's a gray area. And a lot in South Africa regarding termination of pregnancy is actually gray area and open to a wide range of interpretation.
Okay.
Some religious groups will say, but what about the sanctity of life? And if sanctity of life is what is the most important thing to discuss, then viability before or after 24 weeks becomes irrelevant. What about the woman's choice? We preach patient's autonomy. We're talking about the Millennium Development Goals and so on. We say every pregnancy should be a wanted pregnancy. Every woman should have access to contraception, to education. But when it comes to her own body and termination, we are not happy, or sometimes we're not happy. And that is where, again, do we then allow sometimes patient's autonomy and sometimes we don't? We run to the law to say, but the law says so. And usually we kind of blame the law for offering or not offering a termination. What about selective feticides in multiple pregnancies? For those of you who are doing IVFs, I'm sure you have a lot of experience of that. Sometimes you put 2 embryos, you end up having 4 embryos or 3 embryos. And what do you do with those pregnancies? Well, first of all, selective feticide should be considered if there are abnormalities in the fetuses, 1 or more fetuses with abnormalities. When selective termination of multifetal pregnancy is required to achieve a live birth with less risk of neonatal morbidity and mortality of those who are surviving twins or fetuses, and those who are abnormal, you can then terminate and not have an abnormal baby being born. Now we'll spend a minute here. What do the ethicists say about selective termination of pregnancy for the preservation of pregnancy? In other words, you reduce from 4 to 2 to give the pregnancy a better chance to have a better outcome. Well, ethicists, and Frank Chervenak is one of the leading voices here, say that in twins and triplets is not recommended because the evidence says that you don't improve the outcome of a pregnancy if you reduce from 3 to 2 or to 1, right? The numbers are pretty equal, selective feticide or not. But for higher orders, quadruplets and higher, yes, fetal reduction may improve the outcome of the pregnancy and therefore should be considered.
Ermos, can I just say, now you're a maternal fetal specialist, professor at Baylor University. Where do you draw the line between the numbers of reduction? Did you say triplets, yes, or quads, no? So if you go from 3 to 2, does that make absolutely no difference to the survival? Or is it quads to 1? Where's the line in terms of evidence-based medicine?
Look, obviously one has to individualize, but as a general answer to your question, 3 babies, triplets and twins, we normally do not touch them. We leave them as they are. 4 and above, we reduce to 2. Now, you've got to bear in mind the complexity sometimes where the IVF colleague puts in 2 embryos, and then the patient presents with triplets. And the one set of twins are monochorionic, they're identical, and now you are asked to reduce from 3 to 2. You can't do that. Either you're going to reduce the one baby that has his own placenta, which would be a big mistake, because that's the baby with the better chance to do well.
Yeah, I get it.
Or you're going to have to reduce both identical twins, the monochorionic twins, because if you terminate the one, the other one will end up in trouble.
Yeah, you're going to do them both. Yeah, I get it.
Exactly. And therefore, in those cases, we leave them as they are and pray that the monochorionic pair will not develop twin-to-twin transfusion and things like that.
Yeah.
Yeah,
but if quads, there's no question that if you reduce quads to singletons or twins, that will improve outcomes.
Twins. And there are certain rules, of course. You obviously need to assess them all, choose the ones that look good. If all look good, healthy, and you don't see any abnormalities, then you will choose the fetuses that are further up, away from the cervix. So the top 1 or 2 babies, you will terminate and allow the others to continue.
Got it.
So feticide, just one sentence here about feticide, defined as the destruction of the embryo or fetus in the uterus. Usually these can be performed by injection of potassium chloride, lignocane, or ligation of the umbilical cord, which we don't really do in the first trimester, and we wouldn't do in the second and third trimester because of the bigger risks of losing the entire pregnancy. So the best way about it is to do it in the first trimester, when the baby, after his death, will be a small dead tissue with less complications for the rest of the pregnancy. How do the mothers feel about those embryo reductions? Well, the questionnaires that were sent out and were summarized into this slide here, they basically say that really they don't understand exactly what the embryo reduction actually meant to them. However, they felt depression similar to those who lose spontaneously a pregnancy. But when they were asked, well, would you do it again? Despite the fact that they felt guilt, they said that that was actually probably the best thing to do, and they would do it again, despite the stress and the depression. Does the baby feel pain? We don't know. Probably not, at least not in the first trimester. And is it better to give a lignocane as an anesthetic agent rather than potassium chloride? Probably doesn't matter.
And Ermos, now just go back there. Does the baby feel pain? When, there we go. Okay, in the first trimester, you say, oh, obviously, or possibly not. When does the baby feel pain? In which trimester?
It's not clear. We don't know. We do know that the baby in the third trimester starts to hear. It picks up noise. We had these discussions at nauseam during the World Cup, where in I think it was in a few years ago, where there were all the vuvuzelas in the stadia, and pregnant ladies wanted to know, can they go to watch a match where the vuvuzela is going to affect the baby's hearing? And a lot of discussion, a lot of research, and a lot of expert opinions, we agreed that up to 28 weeks, the baby probably doesn't hear. And if the baby doesn't hear, and therefore we feel that the sensory kind of development is not complete by then, probably pain would go in that same category as well, although nobody is sure about these things.
Okay.
And that's why we try not to do these things so late in pregnancy. That's why we prefer to do these things early, because it's a small tissue that will be left behind, and therefore less inflammatory reaction and complications, but also because it is just more, more friendly to the baby.
Yeah.
So, and that's what I just said. Early diagnosis, it's best because then you can do these things early and therefore avoid the late terminations and all the fetocides and all of that. But then again, who decides what abnormality, for example, is severe enough to justify an embryo reduction or a fetocide? Who is decide? Is that the mother? Is that the doctor? Is that a team of doctors, multidisciplinary team? Let's look at that. So first of all, we need to be clear about the consent. The consent, the primary purpose of consent is to protect the patient's autonomy, clearly, and to provide a strong moral foundation in which a patient, adequately informed about her and her baby's medical condition and the available therapies, freely chooses specific treatment or no treatment. And remember, consent is a process, not an event. The patient may actually go home after a long session, discussion with many stakeholders, all your colleagues, and then she comes back the same day or the following morning and says, well, but I changed my mind. Consent is a process. What is important, and our responsibility is always there, is to give adequate information, make sure the patient understands the information you provide, and the decision has to be a voluntary decision. Yeah, we all know this kind of situation. Okay, here's the consent form. It's like a whole book there, and here is what you really need to understand and sign that bottom line. So then, Peter, you were asking earlier, so what is severe abnormality? Is one kidney, no ears, no toes, a cleft lip, Down syndrome? And I put this here, not because of chance, because I dealt with situations where a patient, for example, terminated because of a cleft lip, terminated because of a clubfoot. So is this significant to justify termination? But then who decides? Is it 20% risk of severe mental or physical handicap? Does then Downs qualify because the mental handicap will be more than 20%? But how do we measure? And as we all know, these kids, provided you offer them a lot of stimulation and information and love and care, they will be fine. They will be good members in the society. If you lock them in a room and never speak to them, well, that's a different story. Questions that patients will want to know: is the condition affecting the baby? Is the condition affecting the baby compatible with life? Will the baby have a lifetime requirement to have some assistance? What is the lifespan of this abnormality? Can this be corrected? And these are very simple questions. And I think most of us will be able to give one answer. What about the more severe ones? We all know that trisomy 13, 18, agenesis of the kidneys like Potter syndrome, thanatophorus skeletal abnormalities, holoprosencephalus, anencephalus, those are non-viable. Those are lethal conditions. And therefore, yes, those should not really be even up for discussion if the diagnosis is clear that this pregnancy is doomed not to do well, and therefore termination can be offered. So the discussion carries on. And in many congresses, up to this day, people will go and discuss, do we terminate Down syndrome? Do we terminate spina bifida? Do we terminate the diaphragmatic hernia? And there's the achondroplasia here. Do we terminate babies that are dwarfs? In my practice, I don't. My opinion is that dwarf or achondroplastic babies have a good quality of life. They have fantastic brains, and I would not offer termination, not in my center.
Ermos, that's very interesting, because I had a patient who was an influencer, and I don't know if you know what influencers they on the social media, and every single thing they do is almost advertised on the social media. The clothes they wear, the gym they go to, their beautiful makeup, blah, blah, blah. And then she advertised that she was having a pregnancy, and it turned out to be a dwarf. And this was absolutely anathema to her because she was a beautiful woman with a beautiful life, beautiful partner, blah, blah, and she didn't want an ugly baby. So that's where the conundrum came. And that's why ethics is so important under those circumstances.
Absolutely. So,
But I'm sorry, can I just,
yeah, no, carry on.
No, but just, I mean, like now, so, I mean, you were, I mean, you bring such important topics up here, but like, as you said, in your practice, you don't terminate the dwarfs.
No.
But then it comes down to some another practitioner's decision to counsel a patient in a completely different way. So, and I think that is where these issues really get quite complicated, in that the person counseling always has an opinion.
Yeah, brings to the party their own opinion and their own personal opinion,
and
which
the
might.
objective.
Just bear with me. Bear with me. I will show you 1 or 2 slides further down the doctor's rights. A doctor has rights. The doctor is not obliged to terminate anything, provided he didn't miss the abnormality, because then he would be accused of negligence. You know that. Provided the discussion is being made on the assumption that the patient is clear of what is she dealing with, and you say, look, in my opinion, achondroplastic dwarfism is not a significant abnormality that would justify me performing a termination. And remember, just to clarify things here, achondroplasia is only diagnosed in the 3rd trimester. So inevitably, you will see this baby at 32 weeks, and now you're asked to do a termination because the baby is not perfect. Yeah. Well, I would have a problem to terminate a 32-week baby with dwarfism.
Yeah, absolutely.
Right?
Yeah, no, I agree. That's why we're having this discussion.
And no guidelines or national guidelines on specific condition. It's up to the independent practitioner to make a decision on that themselves.
Yeah, and that's why you call
if the woman is the center of her own care, does she not have that prerogative to demand a termination if it's an ugly child, if it's her wish, if she is the center of her own obstetric care?
Well, that's where the patient's autonomy comes in, which can, she says, but yeah, I reserve the right not to have a child with dwarfism. You say, I hear you, and I feel for you, but I need you to go and see someone else. You may refer it to a psychiatrist. If all else fails, and we have done this. Guys, trust me, this is not something that happens just in the lecture tonight. We have these conditions repeatedly, and sometimes we do chicken out and we send the patient to a psychiatrist who will then say, look, this patient is suicidal and she can't really carry on with life like this, and I recommend termination. Then medical legally makes my life a lot easier. If I have a problem with the principle of termination, that's okay. I will send you to the Joburg Gen, I will send you to Groote or whatever, where this can be offered to you, and someone hopefully there will be willing to do that.
Yeah, got it. Thank you.
So Frank Chevenac says, this should not be terminated because society has a justice-based obligation to look after disabled people. Obviously, clearly, big words for America, perhaps. In poorer countries such as ours and further up north, these may not be applicable. So what do we do with poorer countries? Now we have a patient who lives in a shack, no electricity, no running water, unemployed, and she has a baby, maybe not a dwarf, but a baby that has a spina bifida and will be wheelchair bound. Will that then influence your decision regarding offering a termination? That's something that needs to be debated. So, and brings us to the question of Down syndrome, where Down syndrome, as you all know, is quite a common abnormality in terms of chromosomal abnormalities. And some centers in our country, and particularly I know down in the Cape, termination is not offered to women after 24 weeks with a healthy Down syndrome, not with children with other associated abnormalities like cardiac abnormalities and so on. The the issue I have with that is if a patient booked an early appointment to be seen in our clinic, in our hospital, but because we're so busy, we gave an appointment to come in 3 months' time, and by then she's 26 weeks, is that her fault that we now missed that cutoff point of viability? And therefore we say, well, sorry, we can't really help you. Or do we say, well, you know, it's us that actually made an error here, and maybe we should really help. And that's, again, something that needs to be debated. We do not offer Down syndrome routinely and readily to everybody beyond viability, but it's something that has to be, again, individualized. So, and we're repeating some of these things with the viability. You know, I'm going to go a bit further because now we have a bit of a time issue as well. So what I was saying earlier is the right of the doctor. A doctor cannot be forced to provide these services of termination or even contraception, for that matter, so long as the objection does not contravene relevant anti-discrimination laws and does not compromise the clinical care of the patient. However, a doctor, the same doctor who refuses to do the termination, must provide care if the patient presents after a complication, after an evacuation for termination of the pregnancy and retained products of conception and so on. So you do not want to offer the termination, but if the patient complicates after termination and she comes back to you, you're obliged to treat her. No questions asked. The same with the PID following a session of an IUCD where you didn't want to put it in the first place. The exercise of autonomy by a patient cannot be justifiably oblige a doctor to act in a way that is unacceptable as a matter of individual conscience. You must, however, explain why you cannot offer the service yourself, display respect for the integrity of the patient's values or beliefs, emphasize that the patient is not acting in a morally unjustified manner, and highlighted direct referral. You pick up a phone and phone a colleague that you know may be amenable to doing a termination, and you refer the patient to them. Cesarean section on demand. I don't know if you can read it on your monitors. The farmer says, what are you talking about? Just lay eggs. Chicken says, no, I want an epidural. So the question, of course, of cesarean section on demand, most societies, including our societies in South Africa, this is a paragraph from the Royal College, we sit on the fence. We say, yeah, well, it's a major operation. The patient needs to be counseled that this is a major procedure, and therefore lots of counseling and psychological support and so on. But if she remains certain that cesarean section is the right option for her, then that choice should be fully respected. Now you may say, yes, but what if you have 20 fetal distress on the board? What do you do then? Well, that's something obviously that the system has to deal with, not us as doctors, because obviously we don't create numbers of patients that come to see us. This is the system. But look at this interesting case example here. A patient may decide to deliver or desire to deliver a fatally malformed fetus by cesarean section because she believes that's more humane for her baby to be delivered gently by cesarean section and die peacefully. The doctor, obviously, on the other hand, may say, but that's waste of resources, time and expenses and so on. So doesn't really justify that. But the patient wants to have a cesarean section. In such a situation, the physician has to get other colleagues to sit down and offer more counseling, psychological, and so on, and then make a decision. If the patient insists, at the end of the day, she can get what she wants. What about the opposite? Should the patient have the right to decline a Caesar, even if this means that the baby may be at risk? Again, very complicated. So, and then of course, getting into the more sophisticated stuff. Now, starting to look at prenatal screening, doing PGSs, testing for specific genetic conditions. What if in the future we have to deal with, perfect children, tall children, blue-eyed children, blonde children? Do we then allow this to continue, or do we draw the line somewhere? And it is us and our responsibility to guide the lawmakers to make decisions about these things. And then, of course, the question of microdeletions. A lot of patients go and do these tests and the extended NIPDs without even knowing what they are testing. And sometimes they uncover things that they shouldn't be uncovering. How many of us here today don't know if we have some microdeletion in our body? And if our parents knew about that, maybe we wouldn't be here today. Do we offer routinely microdeletions? Do we only offer microdeletion specifically if we have a genetic condition that has a serious effect on the child's health, and only test those cases? We're nearly done, guys. And of course, this is probably the most important slide of the day. Children's genes are not their entire destiny. Much depends on how much and what kind of healthcare, education, housing, food, and love they're provided. After all, no matter how genetically perfect a child is born, if that supernormal child is put into an uncaring environment, she or he will probably not develop nearly as well as a normal, or even less than normal child reared in a caring environment. Our task as doctors is to create a just society in which imperfect children can thrive. For if we succeed in this task, we may no longer feel a need for perfect children. So satisfied we'll be with our world and the opportunities offered to all human beings equally. Two slides about the new kid on the block. Now we're talking about AI. And as you see, the market is growing exponentially. By 2034, they're talking about trillions of dollars market in AI. And of course, medicine is not immune to AI.
So, sorry, Ermos, the
Yes.
market, what did you say? The market of what is growing? Market science, what market is that?
AI as the concept is everywhere. If you do a Google research now, your first answer will be an AI answer. If you want to book a flight, if you want to anything, your cell phone is all now AI operated. Even they advertise that. Samsung says the first whatever phone with AI as a standard, as a routine. Google is AI. Everything is now AI. So we're talking about everything in our lives, not just medicine. A lot of it is now on. I mean, if you look at Instagram and all the things on social media, experts say that more than 90% of the video clips that you see are fake, are AI. Yeah?
Yeah, no, we agree.
No, absolutely.
Yeah. So, of course, the question of AI in medicine, yeah, and the AI in the way I understand it, and many colleagues like myself, focus on augmenting, not replacing human judgment to ensure, obviously, decent healthcare. So, and of course, if there are, say you search and you find something on AI that gives you medical information that may be actually incorrect, and you give the wrong advice to the patient, who is responsible at the end of the day? Are you responsible, or is the AI responsible? But is AI something that is that a person? Is it a concept? Who do you sue? And of course, the question of machine-human interaction, as opposed to the human-human interaction, is central in this discussion with AI in medicine. Because the idea, at least yet, the AI doesn't have the compassion, the understanding of human nature the way we as humans do. And I'm going to go to I think this is negligence. I was going to text you an apology, but my phone is in there, in the patient's chest. So this is, I think, my very last slide, where, as you have seen here in these slides, or looking at as we speak, so AI in healthcare involves multiple actors. That is, the manufacturer, the hospital that is using AI, the physicians who are using the AI. And because of all these complexities and all these stakeholders, experts and legal minds say we cannot identify a definite answer as to who is responsible for something that can go wrong, and there is a case of liability and medical negligence. And the question remains open. And my advice to colleagues is, do not go by AI, go by your own experience and medical judgment that you have learned for many years. I think I'm going to stop here. This is the last slide. Conclusion: ethics in obstetrics and gynecology is essential in dimension in obstetrics and gynae, guides the obstetrician as well as the parents, helps balancing beneficence and autonomy-based obligations with professional conscience, ensures respect for the patient's autonomy, and remember that we practice within the parameters of the law of the country where we are. And I put here the Groningen Protocol. I don't know if you guys are aware of that.
No, what is the Groningen? Give us 1 minute touch on the Groningen is a town in the Netherlands.
In Holland, yes. So in Holland, the Groningen Protocol says that if a baby is born and has severe malformations, you're still allowed to do not a feticide, an embryocyte is allowed. Legally, you can do that. Whereas in South Africa, that would be murder, of course.
Okay, got it. Groningen Protocol.
Yeah.
Steve, well, that's wonderful, Ermos. Thank you so much for that presentation. Food for thought, and you've brought up some wonderful conundrums to us. I'm going to ask Steve to thank you very much.
Thanks so much. I was just interested to hear your opinions about the AI, and having interacted with ChatGPT quite extensively over the last few months.
You do it all the time, Steve.
Well, I do. I mean, I think it's there's obviously a very human aspect to the way they communicate. And I feel that in the counseling process, it might actually be able to be taught properly to bring a maybe even a more objective counseling strategy to patients. So maybe we mustn't deny too much the role that AI might play. I'm certainly starting to think about developing joint decision-making tools for patients, even with things like stress incontinence, and taking patients through a very robust system to get them to make decisions, because the humans also sometimes obviously carry a very strong opinion themselves, and that comes through to patients, and they might then obviously be influenced by it. But I mean, yeah.
What I wanted to say, and I've got a whole talk on AI, which obviously I didn't want to waste too much time on that. It was a different topic tonight. But we need to basically ensure, if we use AI, that we have the references and the information we get that is above board correct. Because there is some phenomenon called the black box phenomenon. I don't know if you're aware of that.
Yeah.
Where the AI will refuse to disclose the sources of the information that you're provided. And in that case, you are looking for trouble, because you may actually be dealing with things that are incorrect. The
right.
AI will put two and two together and sometimes improvise to give you an answer. Just because, if you ask, for example, if you go to your computer tonight and say, ask AI, what is AI any good? You will get fantastic answers. You will get, AI will do this and this and this. Fair enough. And it has to be used, because if we don't use it, we will be left behind. But we also need to ensure that we are still responsible for our patients.
Yeah,
absolutely. Ermos, I'm going to ask Chris to give you a slot on AI in medicine. I know that the SASOG meeting in August is going to have a section. Dr. Basson has actually done research on AI for her MBA, this AI in medicine and how we should use it. So it is something that is topical. It is something that is something we should confront and see what we can. So I'd love to hear your talk on AI.
Yeah, absolutely. I mean, I think it's becoming so diverse and so universal, and we're going to have to embrace it.
We have to, Steve. So I'm afraid that AI or not, we have run out of bandwidth.
Yeah, and yeah, thanks so much. It then just leaves me to thank you very much, Ermos. Your perspectives are very interesting and very, very thought-provoking. And we do appreciate it. And you speak from a position of authority.
Yep.
You're on the ground. You're counseling patients all the time. And you know what better perspective to have than that. So we do appreciate it, and we are really looking forward to the next few talks you'll be giving us this year. So thanks so much for making yourself available. And again, just thank you so much for doing the talk tonight. And I think that's it, Peter.
Yeah, remember that Ermos does a webinar of his own every Tuesday night, 5 p.m. And it'll be wonderful to attend that. So Ermos, thank you very much indeed.
Yes,
Stay home, everybody.
Yeah, and yes, thanks to you as well, Pete and Chris and the rest of the team.
Thank you
very much. Thank you.
Thank you to all of you guys. Thank you very much, and see you soon. Cheers.